Welcome, everyone, and really grateful for the level of interest and deeply grateful for a wonderful set of speakers who are all active in different ways in the efforts to understand and promote Medicare for All. So I think it's going to be a great day. I'm going to start us off. My charge in the next 15 minutes, followed by questions and discussion, is to review the single-payer vision, scope, and design issues by way of introducing the concept. Let's start with where we are in the United States on healthcare. Here we see the percentage of U.S. adults without health insurance starting at 14.6% back in 2008. Then Obamacare came in, and we saw a drop in the number of uninsured and the percent uninsured, and now it's ticking back up under the Trump administration. So the ACA, if nothing else, greatly decreased the number of uninsured, but that is coming back up. And that is because under Trump, every effort has been made to repeal the ACA. The full repeal failed by one vote when John McCain felt that the whole process was irresponsible. How many of you remember this? Most of you do. It certainly put John McCain in a more favorable light for me. Ever since then, every effort has been made to retrench the ACA. The individual mandate was repealed as part of the 2017 tax cut. The Trump administration fostered a non-compliant health plan. So the ACA requires that health plans abide by some important rules that help the people who are insured, but made a small carve-out exception for brief health plans like 30 days that didn't have to follow all those rules. So the Trump administration redefined the duration of the short-term plans to 364 days. This has not had a huge effect yet, but potentially could. In California, I believe it is, in effect, not a possibility because you lose the subsidies. In general, the subsidies for the poor have been restricted, and now there is a court case running through the courts to try to declare the whole ACA unconstitutional. We shall see how that goes. Aside from the issue of uninsurance, we have a growing problem of underinsurance. This is data, annual data from the Kaiser Family Foundation, a survey of employment-based insurance, which, as you all know, is the single most important mechanism for insurance in our country, and it's certainly in terms of numbers of people enrolled. And on the right is the rise or the number of high deductible plans. And you can see the area that I've circled that the number or percent of high deductible plans has gone from 4% in 2006 to 29% in the most recent numbers. And as this slide shows, the amounts of money in these deductibles are not trivial. The bar on the far right is 2,000 or more. The next bar over is 1 to 2,000. You can see a growth. These deductibles are now, more than half of them are 1,000 or 2,000 or more. And this matters. More than 2 out of 5 adults who are underinsured, such as with high deductibles, report problems getting needed care. So it is clinically meaningful to be underinsured. It hurts people, it kills people. This is a problem. And the ACA, if anything, exacerbated that through the adoption of the low-value plans of bronze and silver plans in the exchanges. U.S. healthcare financing looks like this. I will be sharing these slides to anyone who's interested. There's a video of all of the sessions at the conference, so I'm not going to go through it in detail, but let's just say there are many different ways we pay for healthcare in the United States. There are many different public programs that are nominally 43% of all spending. Private insurance is about 34%. Families pay out of pocket. An important footnote, the public share is actually far in excess of 43%. If you count all of the money that federal, state, and local governments pay for private insurance for their employees, and you add various other kinds of public spending, it turns out, as I noted at the bottom, that about 2/3 or more of all health spending in the United States is public money. So what are the consequences of this? With these thousands of insurance plans, this leads to poor access in many cases through restricted networks, limited choice of providers. This complex system leads to burdensome billing. This has been an ongoing interest of mine. This means a lot of money is wasted on paperwork. And I think David and Steffi will talk about their recent research in this area as part of their presentation later today. There is fragmented and imbalanced price negotiation. In other words, hospitals and insurers have a battle over prices. Hospitals are strong now. Hospital prices are skyrocketing. As a result, we have no effective cost control. So what do we get from this combination of super high costs and super poor access? This is one of my favorite graphs. I did not make this. It is a wonderful graph. It starts in 1974, and each line is a different country. Can anyone find the US here? So as we proceed from 1974, in most countries, life expectancy rose consistently and health expenditures per capita also rose, but at a relatively modest rate. In the United States, since 1974, life expectancy rose, but at a much slower rate, and expenditures rose, but at a much higher rate. We are an outlier. If there were any evidence of the underperformance of our system, here it is. So what do we do? Hey, I have an idea. Single payer. Single payer vision, in my view, is universal, high-quality coverage, which eliminates financial barriers and uses simplicity and price negotiation to reduce costs and removes profiteering. By universal, I mean everyone is covered cradle to grave with broad benefits and with widespread or completely free provider choice. Eliminating financial barriers means no deductibles and low or no copays. This is a topic of discussion, and progressive financing. Using simplicity and price negotiation to reduce costs, that's about having a single payment system with fair provider payments that are negotiated, and also negotiations with drug companies to get drug prices that are more in line with international levels, which are all much lower than in the United States. And I don't have an italicized red explanation of removes profiteering. I will leave that to you. Recently, Christopher Kai and a team which I brought together published in PLOS Medicine the projected costs of single-payer healthcare financing in the United States, a systematic review. This PLOS Medicine, for those who don't know, is completely public access, so if you just type any version of this title in PLOS Medicine, you can easily download this article. What we did is we looked for economic studies of the cost of single payer, including several done by people on our speaker panel. We found 22 analyses. Here you see them arrayed by their final result, the net cost. The red bars show increases in cost because people are better insured. The utilization goes up and costs go up, but that's balanced by the green bars. The green bars are savings due to administrative simplification, lower drug prices, and other reasons. And as you can see at the far left, red is bigger than a green. In that particular analysis, the increase in cost was more than the savings, so a net cost. But only 3 studies are in that category. As you move to the right, you can see, I hope, the blue line that's showing that the net savings in 19 studies was found, and the median savings was about 4%. Some studies estimated more than that. So the evidence is, from these studies, is consistent, that we will save money with single payer. This is another graph from the same paper, and what we do here is break down the kinds of savings. These are organized just by the year the study was done. The red bars are again, the utilization increases, and then we've broken up the savings into different color bars. The black one is administrative savings, the green one is drug savings, and so on. If anyone's interested, you can peruse this in the article. The point is that there is a broad level of consensus that these savings are very substantial and allow us to do something that goes against a basic principle in economics. The basic principle in economics is there's no free lunch. Everything costs you something. I propose that for single payer, you save money and you improve health. It's like the old beer commercial, tastes great, less filling. How can you go wrong? Single payer scope. Who's included? Ideally, all residents and undocumented. What's covered? Medically indicated care, including inpatient ambulatory drugs, and ideally, and this varies by systems, but ideally long-term care, vision, hearing, dental, ample mental health and substance abuse, and any modality with any reasonable evidence of effectiveness, and controls. One of the strategies that single payer uses is controls to limit costs. Macro, it's done with global budgets. If you have a global budget that determines how much spending can rise, it's been proven over and over in many, many countries that you can control the rate of growth versus what we see in the United States. And then I also like to include micro evidence. This is something I've done professionally for decades. Evidence on effectiveness. Is there evidence that things work? And even, and I say this, great hesitation in this crowd, cost effectiveness. I think there is a place for looking at making sure that the money we spend, the money we have available, is spent well, and it needs to be done transparently instead of how it's done today, which is opaquely and unfairly, and it's also a great tool to negotiate lower prices. If a drug is developed and the price makes it not cost effective, you go back to the manufacturer and say, give us a 50% price reduction. So it's a great tool. So the whole purpose of this conference is to look at design issues. How do we do single payer right? How do we be true to Medicare-for-All, to that vision, while considering variations on the theme? And as a preview of what we're going to talk about today, first, we're going to start with a wonderful interview filmed by my good colleague in this movement, Andrew McGuire, with Pramila Jayapal. She was originally slated to be here. There's a congressional delegation to the Sudan, which she couldn't miss, so with great apologies, she won't be here, but she did set aside time for this video to address the conference. We'll start with that after this session. We'll then look at core features of health systems and insurance from other nations. One that I like to emphasize is a single standard benefit plan. In the United States, we don't talk about much about the fact that there's this incredible diversity and confusion of benefit plans. In other countries, there's just one main benefit plan. Financing, sufficient and progressive. The role of private insurance, should there be a role in providing complementary or supplementary care? We'll hear about that. We're going to talk about what I call the NHS, or National Health Service option, which is the VA. Should we open up the VA to other people? We're then going to have something on my favorite topic, because this is part of what I do on modeling. How do we model health system change? And in particular, how do these design considerations and assumptions translate to results? We'll then go on to provider payment. How do we best set that up? Long-term care, a very important issue that's often neglected, but is very much in the single payer mix. And finally, how do we get there? How do we set the stage for political support? How do we do a transition that facilitates moving from our current system to single payer? And I will stop there. Thank you for listening. And I think I'm actually on time. Have I done well? The timekeeper is down here.